going to be a great team. Today we shall be looking at a deteriorating patient in the ICU. And we have a great team that has put this together for us today. So I'm going to be introducing them one by one as we continue. So let me have Kathy, come and introduce yourself.
I work in the level with the therapist people, and then in this scenario, I'm going to be the.
Thank you. I hope you are all able to hear Kathy. So let's have the next person, the next expert. So we have Simon. Kindly come and introduce yourself.
Hello, everyone. My name is Simon Tumusime. I'm a medical doctor, an emergency care enthusiast. I'm very passionate about emergency care. I'm part of the trainers for ITLS, ALS, BLS, basic emergency care course. I'm happy to be part of this facilitating team.
We're excited to have you, Simon.
All right.
Let's go to the next expert that's going to be with us today. Please come and introduce yourself.
Good afternoon, everyone. I'm Naloza Wendy. Third year at Deteriorating. In this scenario, I'll be the intensivist to receive the patient in ICU.
Thank you, Wendy. It's exciting to have you in this particular echo session. Yes, Brenda.
Good afternoon, everyone. I'm called Brenda. I work as an ICU nurse. In this scenario, I'll be working as a nurse. Thank you.
Thank you, Brenda. It's exciting to have you as part of the panelists today. And let's have Rebecca. Let's give her the mic. Thank you, Rebecca. And let's have the next panelist, Charles.
Yes, good afternoon. I'm Dr. Charles. I'm resident of anesthesia in Ethiopia. I'm happy to be here today and share knowledge. In today's scenario, I'm going to be a fellow, an intensive care fellow. And I hope to share something good with you. Thank you.
Thank you, Charles. Exciting. We are going to be having a fellow in this scenario. Next, we also have Dr. Erasmus Ukelo online, and I'm going to take the pleasure to have him introduce himself.
Hi, everyone. My name is Ukelo. Looks like I have a bit of feedback. I am an intensive care physician, background from anesthesiology, and I will be answering questions on the chat. I work in two places which are relevant to this talk. I am a teacher at Makerere University, the Department of Anesthesia and Critical Care, emergency medicine, but I'm also a practicing physician in the ICU, heading the TMR intensive care unit. So today I'm in that capacity as attending physician and head of TMR intensive care unit. Thank you.
Thank you so much, Dr. Rasmus, and we are glad to have you in the chat. So Dr. Rasmus will be attending to all your questions, comments. I will invite you to post any question that you have as you follow the scenario, any comments that you'd love to make, any clarity that you'd love to seek in regards to the scenario or the simulation. Feel free to post them in the chat, and you will be sure to get the answers to those questions or comments. And also, we shall be having, of course, a debrief, which will be like a discussion of the case. And we might also go beyond just the case and look at critical care of deteriorating patients in the ICU. And for that as well, we shall expect your engagement. We shall expect you to be part of the conversation that we shall be holding. We're going to have the case of the day just projected as I invite Simon to come and take on.
Thank you, Dr. Jimmy. All right. The team here, the emergency physician, could you please come over? Nurse Brenda. Okay. All right. So this is. All right. So our education goal today is, our goals today is to make sure that learners gain reflective experience in the management of acute life-threatening conditions. We have a few objectives in terms of what is involved in ICU preparation and early team role assignment. We are also going to look out for communication between colleagues working together. We'll be paying particular attention to handover communication, particularly to something called the ISBA. And we'll also see how the multidisciplinary team work together in terms of trying to ensure that the objectives are obtained. We'll be stopping in the middle for pause to continuously engage you as the community for your feedback, so that this is more of an interactive session. So I'll be pausing once every moment to let you answer the polls that will be shown on your screen. And then after, we'll resume the case scenario. All right, so I'm going to provide the case scenario. So this is building on to what we've been covering in the past couple of weeks. We've been looking at the same patient. We started the journey from Masaka Regional Referral Hospital, and now we went to Mulago National Referral Emergency Unit, and that's where we'll be picking our case from. The same case, this is the third time. This is our third case scenario. The patient is the same. We have a 30-year-old patient called Mokasa John, who was involved in a road traffic accident. He's a motorcyclist, was driving at a high speed. He sustained multiple injuries and severe traumatic brain injury. He was admitted at the emergency unit, and so we are going to pick it up from the emergency unit at Mulago National Referral with our attending doctor, Dr. Simi Rebecca, having stabilized the patient and preparing to hand over to the ICU team. All right, Rebecca, are you ready? All right, so remember, this is Mokasa John, 30-year-old male who came in with polytrauma and severe traumatic brain injury. This was all following a road traffic accident. It was a motorcyclist driving at a high speed. You've stabilized him before. You're preparing to hand over to the ICU team. Over to you, Rebecca.
Hello? Hello?
Hello.
Good afternoon, Dr. Charles.
Yes, good afternoon, Rebecca.
Yeah, my name is Dr. Asimire. I'm calling from Mulago National Specialized Hospital Emergency Department. We have a 30-year-old male who is a referral from Masaka Regional Referral Hospital. He's a polytrauma patient who has severe traumatic brain injury following a high-speed motor crash along the way. Currently, he's intubated and sedated in the ED. His GCS is 3 out of 15. The left pupil is 6 millimeters and the right pupil is 2 millimeters. The brain CT scan is showing diffuse abdominal injury with cerebral contusions and cerebral edema. He's currently hypertensive with a BP of 140 out of 85 and a heart rate of 100. He's currently saturating at 100%. We are bag mask valve ventilating him, and he's receiving hypertonic saline, he's receiving IV Keppra, and is currently deeply sedated. Neurosurgery and orthopedic team have been consulted. However, on arrival, rather on transit, he had seizures, he vomited, he was desaturating while in the ambulance, and they stabilized him by giving him IV mannitol, phenytoin, and oxygen therapy. While in the ED, we performed rapid sequence intubation with mid-inline stabilization. We gave osmotherapy with hypertonic saline. We did a brain CT and an X-ray of the left femur. And in the labs, his HP is 8.4, the electrolytes are all normal, and the platelets are normal. He's an occasional alcohol user, and he does not have any smoking history. Also, he does not have any significant past medical history, and there isn't any known allergies in his history. So in assessment, we are managing severe traumatic brain injury with radiological evidence of increased ICP, and also a left-sided femur fracture, a closed left-sided femur fracture. He's currently hemodynamically stable. However, he has worsening neurological signs. Currently, he's under sedation, and we are currently bagging him. So we recommend that he should be admitted to the ICU for advanced neurocritical care, and also for sedation and ventilation targets for ICP control, and also for fluid and electrolyte monitoring. And we also recommend neurological and pupil reflexes to be reviewed every hour. Neurosurgery and orthopedic shall review him in the ICU. His family needs to be updated, and we shall transfer all the records with him as we bring him to the ICU.
All right. All right, thank you, Dr. Rebecca. So we're going to pause, and there'll be a poll that's shown on your screen. When we come back, we will hear from the ICU team, having received the patient, preparing to send someone over to come and review. Okay, so having we're done with the poll now. We're going to end it. Let's see how many people got it right. Okay, I can see that very many people are familiar. So the correct answer is the third option on your screen. That is, it's the identification, situation, background, assessment, and recommendation. That's what ISBA stands for. So I stands for the introduction, situation, background, assessment, and recommendation. Okay, so we're going to come back to the ED. Before we come back to the ED, we're going to see a conversation take place in the ICU with the ICU team, having received the last time a phone call from the emergency unit team.
Yes, Dr. Winnie, I've received the call from our EP team,
Okay.
the emergency department team. They have a patient, a 30-year-old male. So they have a patient,
Okay.
a 30-year-old male, referral from Masaka Regional Referral Hospital, who was involved in a road traffic accident,
Okay.
a high-speed motorcycle crash. Yes, so currently he sustained a severe traumatic brain injury and then a fracture left femur closed.
Okay.
Yeah, so currently is intubated and they are doing bag mask ventilation.
All right.
Yeah, so and they are giving the fluid. So and the vitals seem normal that they are communicated. So, but they want us to take over to assess and see if we can take over care.
Okay.
To do advanced care and then also monitoring.
Okay. Thank you for that summary. Do you mind going over to review the patient before we admit? And when you're there, could you kindly give me a call so that we prepare for whatever they need?
Right now.
All right. Thank you. We shall be waiting for your call.
All right, thank you. So you've just observed a conversation happening in the ICU. Now, Dr. Charles is going to make his way into the emergency unit to assess and prepare the patient for possible transfer to the ICU. So, Dr. Charles.
Yes, Dr. Rebecca.
Welcome, Dr. Charles.
Hey, good afternoon.
Good afternoon.
Yeah, so may I have some gloves?
Sure.
Yeah, so let me do the assessment, then see how to proceed. So I can see in the air and cervical and the C-spine.
Yes,
the C-spine is immobilized.
Yes, it is immobilized.
Okay, and the air is intubated.
Yes, there is the patient is currently intubated. Yes.
Yeah, and the tube is secured.
Yes.
So we are bag mask ventilating.
Very good.
Okay, may I have stethoscope? Thank you, Dr. Rebecca. Yes, so let me listen to the chest and see if we have equal air entry.
So when Brenda ventilates, there's good air entry and there's good chest rise. And she's also ventilating at the rate of 10 breaths per minute. So every 6 seconds.
What is the oxygen saturation?
When you check on the monitor, the SpO2 is currently 100%.
Thank you. So I think we'll continue the bag mask ventilation. Then when we go to saturation, okay, I can see we have two large bore cannulas and then we are running fluid.
Yes.
The extremities.
The extremities are cool.
Okay, the cup refill.
The cup refill is 5 seconds.
Then the pulse.
The pulse is 100 and a bit weak.
Bit weak.
Yes.
Okay. Blood pressure.
When you run the blood pressure, after you run it, it gives you about 140 over 85 millimeters of mercury.
So 140 over 85 with some signs of poor end organ perfusion. Then our JVP.
No, there is no JV.
Listen to the chest, the breath sounds.
The heart sounds 1 and 2 are hard and they're not muffled.
Thank you. So we have stopped despite having a normal blood pressure.
Yes.
Yeah, so I think we continue our fluid and then we prepare also.
Yes. So the patient is
is
currently on 1 liter of fluids that's running 20 mils per kg. That's the rate we are using. And the ED team already started that.
How was the EFAS?
The EFAS was negative.
Okay, thank you. That is good.
Okay.
Let's proceed to disability. You say it is sedated? It's deeply sedated. Okay. Yeah, so it's deeply sedated. That's what. So I think we can proceed to pupils.
Okay.
Let me examine the pupils. Continue the bagging.
So when you examine the pupils, you find that the left is about 2 millimeters, the right is 6 millimeters, and mildly reactive to light. Yes.
Yeah. So what is the RBS?
When you take a random blood sugar test, you find it's 9.9 millimoles per liter.
Okay, thank you. I think we can elevate a bit the head of bed.
Okay.
Continue the bagging and then the food.
Okay.
Yeah, so let's proceed to exposure.
Very good.
Yeah. What is the temperature?
The temperature is 36 degrees Celsius, and the patient is somewhat covered. So,
okay. Thank you. No signs of active bleeding.
So there's no signs of active bleeding. However, you see a large dressing on the left thigh, quite where there was a femur fracture, splinted, but you see a large dressing there. And then that was confirmed on X-ray. So it has a left femur fracture, and that's where the swelling is. And then you also note some bruises and abrasions around the left limb and the right limb.
Okay, so I think we continue the immobilization.
Okay.
And then we ensure we maintain our normal temperature.
Okay.
Yes, so let me proceed to inform the attending intensivists.
Okay, very good.
Duty.
Okay.
Hello.
Hello, Dr. Charles.
Yes, Dr. Winnie, I've seen the patient.
Yes, please.
Yeah, so I want to give you an ISBA.
All right.
What on the patient. So introduction is Pastor John is a 30-year-old male referral from Masaka Regional Referral Hospital.
Okay.
So situation is sustained a road traffic accident. Was a high motor vehicle crash.
All right.
Yeah. So currently sustained a severe traumatic brain injury.
Okay.
And closed left femur fracture.
All right.
Yes. So and currently in the assessment, his airway is secured. We've intubated. The tube intubated, and the tube is secured.
Are we bagging or
we are bag mask ventilating.
All right.
Yeah, we have equal air entry and bilateral chest rise with a saturation of 100.
Okay.
Yes. Cardiovascular wise, we have a cup refill of 6 with a pulse rate of 101 with a weak pulse. Okay, and a BP of 140 over 87. There is no raised JVP. The outcomes and 1 and 2 are hard and clear.
Okay.
So, and the EFAS was a negative. Okay, on disability, it's currently deeply sedated, but we have unequal pupils. Okay, with the right one being 6, the left one being 2. Yeah, so and currently the team has given anticonvulsant Keppra and is also on chemotherapy. The blood sugar is 9.9, okay, and the temperature, on exposure, the temperature is 35, okay, and then he has no active bleeding, but the left lower limb is immobilized.
That's good.
Okay, yeah, so, and the team, as the team requested me earlier on, so I think we need to prepare and bring him in.
Okay.
Okay, for advanced neurocritical care, advanced neurocritical care, and also invasive monitoring. So I think we should prepare a bed, a ventilator, a suction, monitor, and also infusion pumps, because we might need to support his cardiovascular system also. And also we prepare drugs and the other things we use to monitor, to manage increased blood pressure.
Thank you, Dr. Charles, for the assessment and the report. I've noted the recommendation. Let me speak to the team. We create the bed, the equipment you've mentioned, like suction, infusion pumps, ventilators, and any medications that we may need to manage potential ICP because of the severe traumatic brain injury. Do we expect any other teams to come and review this patient?
Yeah, so the ED team was already consulted the neuro team and the orthopedic team, who have advised that we first stabilize the patient, then they will come and also give their input.
All right, thank you very much. I think we shall be ready in about 15 minutes. We shall give you a call for the patient to be transferred. Thank you.
Thank you. Dr. Rebecca? Yeah, so the team has received the information, and they have said they are going to be ready for us in the next 15 minutes. So meanwhile, we can continue the support we are giving the patient here as we wait and also prepare to move the patient. So let's also set up transfer the patient. Thank you very much.
All right, thank you, Dr. Charles and Dr. Rebecca. Now, as they're preparing to move the patient to the ICU, we are going to run another poll. It's coming up on your screen very shortly. Yes, so when we come back, we'll now be in the ICU and the team will be responding from within the ICU. Thank you. Okay, so we're back. Thank you all for the ones that have attempted the poll. The correct answer, as seen on your screen, is the third option on among the four listed above that, clearly stating current concern and what is needed. So that is the right answer. For those that have answered it, got it, congratulations. We're now switching back to the ICU now. The scene has changed, so we're now back into the ICU. At this point, Dr. Charles has already handed over to Dr. Winnie, and the team in ICU has already received the patient, so they're going to do an assessment as you watch. All right, over to you, Catherine.
So in the ICU, we have received the patient, the ICU bed, and we have our ventilator here. So the patient will be switched from the arm bag to the ventilator.
Very good.
Okay. So the airway, the patient is
Yeah, so the patient is intubated as you're switching to the after switching to the ventilator machine. The airway is still okay. You don't see any secretions in the mouth. The airway seems patterned with the intubation.
So I am connecting the patient to the ECG.
Very good.
When I look at the chest, the breathing.
So the chest rises with every ventilation according to the monitor. There's good chest rise. You can check for air entry.
The check for air entry.
There's good air entry bilaterally, and there's no added sounds.
The SPO2.
When you check on the monitor, SPO2 is 100.
When I feel for the extremities.
The extremities are still cool.
Capillary fill.
The capillary fill is 4 seconds.
And the pulse.
The pulse is 80.
Volume.
The volume is still slightly weak.
Okay. The blood pressure.
When you run, the blood pressure hasn't changed much. It's 140 over 87.
IV access.
Yes, 2 large bore cannulae connected already. Fluid is running.
When I check the neck.
The neck veins are flat and the trachea is midline.
I go to the D.
When you try to, when you do a sternal rub, the patient has no eye opening, no verbal response, and there is no motor response.
How is our sugar?
When you do RBS is around 9.8 millimoles per liter.
Look at the pupils.
The pupils, the left is 2 millimeters, the right is 6 millimeters and minimally reactive.
I expose my patient.
When you expose, you see the left side immobilized with some large swelling on the around the thigh. Then you don't see any other active bleeding. There's just some slight bruising on the left and right limb.
And how is our temperature?
The temperature is 36.
Yeah, so the pulse rate. Pulse rate is
So,
and then the blood pressure is
189, yes. Yeah,
so as I can see,
so the blood pressure is 180 when you run it, 180 over 100, and the heart rate has dropped.
All right. So we are having changing vitals. We are going to do the ABC again.
Okay.
All right. The airway.
Yeah, the patient is still intubated. There are no secretions in the mouth. Airway is cervical spine is immobilized.
All right. Respiratory rate.
Respiratory rate is now a bit 20.
It's at 20.
It's respiratory rate is respiratory rate is 20.
Rate is 20. Air entry.
Air entry is good. Every time there's ventilation, air entry is good.
Okay, we have ventilating at what rate?
What? Sorry.
Respiratory rate On the ventilator.
On the ventilator, it's 10.
It's 10 and we are breathing at, okay?
Yeah.
All right, then circulation.
What do you want to know?
Are the hands warm?
The hands appear cold.
Okay, cup refill.
The cup refill is still 5 seconds.
That's elevated. Pulse rate.
The pulse rate is 60.
60 is still dropping from 85 to 60.
Yes.
BP.
The BP is 180 over 100.
So we have an elevated blood pressure and we have bradycardic at 60. All right, we're running any fluid?
Yes, running fluids. Yes.
And since how much fluid have you run?
You did 1 liter the last time the patient came from.
Okay, I would like to check the pupils. How are they?
The right is 6 millimeters, the left is 2 millimeters.
Okay, we have anisocoria. Are they reactive?
The right is minimally reactive.
All right. So we have high blood pressure of 180 over 100.
Yes.
We have a bradycardia of 60. We have anisocoria. And the respiration is also irregular.
Yes, it's irregular, it's fluctuating.
All right. So given the history of the patient and the current picture, I think we have elevated intracranial pressure.
Very good.
Yes, so we're going to institute measures of to reduce the pressure. We're going to begin with elevation of the bed. All right.
All right. So thank you, Dr. Winnie. We're going to stop briefly and show up a poll, and then we'll come back and resume. Dr. Winnie will take it on from there. Okay, so the answer to that poll is the second option. We're asking what are the most concerning combinations of signs suggestive of raised intracranial pressure with impending herniation. And right answer is a blood pressure of 180/100, a dropping heart rate below usual normal, so probably 50. Right pupil 6 millimeters, so they're both unequal and non-reactive. That's the most correct answer. We're going to stop that and then run another poll immediately to find out what do you do after you've identified those signs. So you can tell us in the next poll. We're waiting for the next poll.
Moving forget.
All right, welcome back. So this is our fourth poll. The correct answer is the last option, which is the question is, which of the following is not part of the first line of ICP lowering measures? And yeah, there's no need for 1 liter normal saline bolus over 15 minutes. The rest are measures that we use in lowering ICP. So we're going to come back to our case scenario and come back to the ICU and see what Dr. Winnie is going to do. We stopped when she had identified signs of ICP with impending herniation, and we're going to see what are the measures she's going to take to try and mitigate that. So over to you, Dr. Winnie.
So our patient has increased intracranial pressure, and we're in the ICU. Patient is ventilated. So what we're going to do is sensitive measures to reduce that pressure to prevent herniation. The first measure is going to be to request minus to raise the head of bed, which has done to about 30 to 40 degrees elevation. Are we running hypertonic? All right, continue running it, 3%. Then did the patient get Keppra? Any anticonvulsants? All right. We are also going to how sedated is the patient, because we want them very, very deeply sedated. Could we assess the rest of the patient and administer appropriate sedatives? All right, so we assess the rest. Now, Mukasa.
No response, doesn't talk to you.
Any response to pain?
No response to pain. Doesn't open eyes, and there's no verbal response.
All right, so we are having a RASS of about -4, and we prefer it at that point, -4, -5, to deeply sedate the patient. The other measure would be to, what else? We've sedated the patient. Since the patient is also intubated, we can hyperventilate. We can increase the respiratory rate to about 30 or 35.
Perfect increase to 35.
Thank you very much.
What's your target in tidal carbon dioxide on the?
So we target N-tide of about 25 to 30, not below that. Yeah.
Okay.
I think those are the measures. Then what is the current, so after instituting the measures, we'd like to reassess the patient.
Yes.
To see the improvement in the measures.
Yes.
So we check the pupillary reflex. What's the response?
Mildly reactive.
Mildly reactive. Blood pressure.
Blood pressure is now dropping. It's now, when you run it again, it's about 160/70.
160/70. Heart rate.
Heart rate is now 90.
90, from 65 to 90. Okay, so given the findings we have a slow response to the interventions that we have instituted.
Yeah.
So we are going to think of the next. Okay.
All right. So you're going to we're going to run another poll and see see what are your next steps. Okay, so we're just going to go ahead and proceed. You're going to prepare and you
Continue, yes.
all right.
So we have instituted the interventions and we have a slow response. The patient had severe traumatic brain injury and we are having increased ICP and the patient would herniate. At this point, we are going to call for neurosurgical consult to consider decompressive craniectomy.
Yes.
So I'm going to give a call to the neurosurgeon to see in case you can have an urgent decompressive craniectomy.
Okay, wonderful. So I see the poll has come up on your screen. Thank you, Dr. Winnie. We'll just move over and let the participants answer the poll and see what are the next steps. All right, welcome back. This is the last poll, and yes, the question is: a sedated TBI patient in ICU develops a fixed dilated right pupil and heart rate drops to 48. What is the most appropriate immediate action? And the most correct answer is the third option. Start ICP lowering protocol and call the neurosurgery team urgently. So we're going to come back to the ICU and see. Last we saw was Dr. Winnie institute along with the team start the ICP lowering protocol to try and reduce the ICP. She was mildly successful, but she wants to call the neurosurgery team in case this patient worsens and does and for a decompressive craniotomy. So over to you, Dr. Winnie.
Okay. So I'm going to consult the neurosurgery team to consider the compressive craniotomy. I'm going to call. Hello, Dr. Muhumuza.
Good morning.
Morning. I'm called Dr. Winnie. I'm calling from Mulago ICU.
Dr. Winnie.
Yes, I have a consult to make to you. I have a 30-year-old male called Mukasa John. He's post-TIV and he's intubated and is currently deeply sedated. He has pupils now that are unequal. The right is 6 millimeters. He has a bradycardia at 52. The BP is elevated at 180/100 despite our interventions. And the CT of the brain that was done at the ED showed diffuse axonal injury. It has a contusion and also cerebral edema. We've already given osmotherapy with hypertonic saline 3%, and it's still running. We've deeply sedated him. We have elevated the head of the bed, and we seem to have very mild response to those measures. The GCS is still 3T, and the RAS is -5. We have a Cushing's reflex given the vitals, and we have very low response to what we've given. So we had called to request for your review, potentially to consider urgent decompressive craniotomy, either in this ICU or in theater.
All right, Dr. I can continue with the care bundle and ICP lowering strategies. I'll be there shortly.
Thank you very much. I'll be happy to have you.
All right, thank you, Dr. Winnie. Okay, I think that brings us to the end of our simulation scenario. We're just going to set up and have a debrief. In the meantime, you could offer us any feedback. If you have any questions that you would like to ask us, you could also ask them. You could send them in the chat, or you could also unmute them. All right, thank you. Welcome back. Thank you all for staying with us for the entire simulation. Now back to the for the debrief to see what we discussed and see what we so far seen and discussed already. So before we start, we are going to, this is the entire team. We have the ED team here. We've been joined by Dr. Jimmy to the debrief session. We also have the team that primarily was based in the ICU. We want to start with the emergency unit team at Malago and discuss, could start by telling us what went well, talk about the case scenario, and then also tell us why did you make a decision to transfer this patient or call the ICU.
Thank you very much, Dr. Simon. From the ED team and perspective, what went well? I hope we're able to demonstrate the communication between the ICU team and the ED team, the prompt consult that was made, and the multidisciplinary that was involved in the management of this patient. If you followed from the last two sessions, you realize that this patient is a polytrauma patient with severe traumatic brain injury who had convulsions and had aspirated, and he had an airway and breathing issue from the last session. So we made a decision to intubate the patient. We also realized that this patient could also be suffering from increased intracranial pressure, and we went ahead to start to initiate ICP lowering strategies. So the reason why we wanted this patient to be admitted into the ICU was for both cardiorespiratory support, but also for advanced neurocritical care and monitoring, as we have demonstrated in the simulation.
All right, thank you, Rebecca. Can we also hear from Brenda, you being part of the team in the emergency unit? One of the things we are also assessing is how the communication happened within the unit. So you could provide us from your perspective as the nurse assisting within the emergency unit, what went well, what did you like about your management and the decision and the decision making that you decided as a team?
Okay, thank you. As I was part of the emergency team, how we received the patient at the emergency department, we were able to put the interventions, the patient came in, we were ready to work on the patient, and the interventions that were there as a nurse and the whole team, we worked on them on time. And also the communication from the the emergency department to the ICU, the information was given in full, and the people who responded in ICU got to understand the patient were received and the situation, and they were there to advance the care. So I think we did well on how we cared for the patient and on how we handed over the patient to the ICU team.
Okay, thank you, Brenda. So one of the things we remember from our scenario was that this is a patient who needed continuous ventilation. And as the doctor was given the scenario of the team to come over to the ICU, you did a great job to keep supporting the patient. So well done, Brenda. We're going to move over to the ICU team and find out. Dr. Chow, you were the first one to be notified and to come and assess the patient. What was your initial idea when you got there? And then when you transferred the patient, go over to the rest of the team that assist afterwards. But what was your initial idea and initial reaction when you first assessed the patient?
Yes, thank you. First, the ED team did a great job, quickly identifying that this is a patient who will need advanced support. Okay, and then informing the ICU right away. Okay, and then the communication being clear and structured and very clear. Okay, helped for us to made it easy for us to come in quickly. Also, to evaluate, make the decision transferring the patient. Yeah, so obviously, the first instance of getting the call and the information, okay, I had to go and assess and really see whether the patient really had these features or the problems that would require the patient to be admitted to our unit in ICU. Okay, yeah, and and the assessment is the same where we do ABCDE. Okay, so to look out for those life-threatening problems. So definitely, as I was assessing, to look out for those problems that will be managed in the ICU. So I phoned them. Okay, yeah, and then agreed with the emergency department team, and then had to communicate to the attending intensivist, prepare, and then we take over the care for the patient.
Nice. Thank you, Dr. Charles. What is very important here is to note that once the emergency unit team decided to move the patient to the ICU, the ICU did not just say, bring that patient. The team from the ICU had to send someone to do a prior assessment, assess whether that patient really needs to go to the ICU. And that's what Dr. Charles did very well. That's something that we want everyone to pick up on. You have to actually do your own assessment, make sure you understand if this is a patient in ICU or this is a patient with another transfer. Now, Dr. Charles, once you made that decision, you called and then transferred the patient to the ICU. What was very important to notice is how the team was communicating within the ICU. When we got to the ICU, the patient was immediately assessed by Sister Catherine, right? You could tell us what was your initial assessment when you first got there and how the patient situation changed before you can stop it.
Thank you, Doctor. In my initial assessment, you find that the patient seems to be stable, although sometimes such a patient could look stable while they are compensating. So you saw we went through the ABCDE of the patient and was stable, but at the end of the assessment, our patient changed condition, and then the doctor had to come in to intervene. So as an ICU nurse, doing your ABCD is quite very important because you could have a patient who's seemingly stable, but as you do your assessment, things can change. And if you can catch them early, your intervention can be a success.
All right, thank you, Sister Catherine. What is very clear from this is that the role of assessment does not only belong to the doctors. The role of assessment is for the entire team, and everyone needs to know what to do in terms of assessment. So it was very nice that when the patient got to the ICU, it was Sister Catherine who actually got into the assessment, did the self-primary survey, then noticed some signs and called in the doctor immediately. So we'll go to the doctor. Dr. Willie, tell us what things alarmed you to this patient that weren't there initially when you first had the case as initially handed over by Dr. Charles.
Thank you very much. So what allowed me to appreciate the team that I worked with, that they were able to, as you just said, be able to assess a patient very quickly, and then allow me when the patient changed condition. So what alarmed me was the change in heart rate that dropped. There was initially we had a heart rate of 80. The ED reported heart rate of 100. Then at admission, minus told me a heart rate of 80. And then they called me when it was 65. So the gradual reduction, the 65 as a figure may not allow me sometimes, but the fact that there is a trend, and that is due to communication, there's a trend of drop. So that easily tells me that something is wrong. Then the other issue was the blood pressure. Still, it was initially relatively normal of 140/85. That is from the ED. Even at admission, it was still the same. When they called me in, it had increased to 180/100. So still, I appreciate the communication and flow of information, because when I'm able to have a handover report and also vitals at admission, I'm able to trend and see most likely what is going on, other than just having one figure. It will be hard to interpret. So when I combine that, and also the pupils had changed. So when I combine that with the patient's history, I'm able to most likely know the diagnosis at hand.
All right. Thank you, Dr. Winnie. What I like from your assessment is that everything builds onto another. This is the same patient from the emergency. When the patient was, we first received the patient, what was clear was that the patient did not have signs of the ones that you talked about, but had signs of shock.
Yes.
Right? And then you notice, besides patient still being shock, there was some arrangement vital which suggested other.
Yes.
Then you had to take something. Now we're going to, before we get into the real discussion, I want to bring in Dr. Wikipedia to first of all summarize for us what we've discussed thus far, and also partly also lead the next part of the discussion where we get into the real needs of the discussion in terms of the complications that the patient has.
Thank you so much, Simon, for guiding us in the simulation and also just to re-echo that already emphasized that debrief is quite important, not just for simulation, but even when you manage the patient report. Every time you troubleshoot any challenges that you encounter in patient care, it's important to you to get down and debrief, because helps you to identify some of the things that we need to strengthen as you manage the patient. And I think that has been pretty well done in this scenario. And so we have been running this case for the past 3 sessions, and this is the same patient that got involved in a road traffic accident along Masaka Highway. I was taken to the emergency department in Masaka, managed from there, then they got realized that the patient needed some of the things and intervention that they weren't able to offer. From Masaka, and the patient gets transferred or referred to Milabo for neurosurgical care and as well CT scan that they did in Masaka. The ED team did a good job to manage the patient, and kudos to Rebecca for the job well done. But I just want to ask Rebecca, because she managed the patient and intubated the patient. And I thought that after intubating the patient, she would just carry the patient and rush to the ICU. Because I noticed that the nurse was bugging the patient for quite some time. And to me, I thought that she was supposed to just carry the patient and run to the ICU so that we can maybe relieve the nurse from the stress of having to bug the patient. Why was it important to call the ICU?
It's important for it was important for us as the ED team to call the ICU, not only for them to come and make their assessment, but for also to help them prepare to receive the patient. As you saw in the simulation, the ICU was able to prepare the necessary equipment, the bed space, and adequately prepare themselves to receive and manage the patient, as opposed to what people might think, just intubate, take the patient to the ICU. You might find they are not prepared, there's no available bed space, and you have to plan and re-strategize. So it's important for the ED team to first consult the ICU.
Thank you, Rebecca. A number of them we have actually seen people rush with the All right. Are you able to hear us? Yeah. So, okay. Thank you. Thank you. So, I was making a point that when Rebecca gets to call the ICU, the ICU, instead of telling Rebecca to rush with the patient, they instead chose to send a staff from the ICU to go and assess this patient. And I asked myself, what is the importance of that? Why is that important that actually a team member from the ICU goes and does the assessment of the patient before the patient gets brought to the ICU? Charles, you chose to go to the ICU. What was the main reason for you going to the ICU, to the ED, sorry, to assess this patient?
Yes, thank you, Jimmy. Now, we all know that ICU ICU is a resource that is scarce. So there are normally a few beds, and yet there are very many people who need those beds. Yeah, so it is very important when we are giving this care or this service to ensure that we manage to give those who need it most, okay, to utilize this service in the best way. Yeah, so it's very important to first, for the ICU team to first go and assess the patient, okay, to see whether the patient fulfills the criteria for admission to ICU. In some of the patients we might have on the wards in the ED or in theaters where the teams think might need or may benefit from the ICU service, may actually benefit from being offered another service somewhere, or may benefit from just the advice from the critical care team. And then the patient can remain on the ward or can remain, and then can be managed on the ward with the support of the ICU team. So for those who really badly off and cannot be supported on the ward, those are the ones who would want to move to ICU so that we can utilize the ICU beds to the maximum. So it is important to do that, to first evaluate the patient and see whether it fulfills the criteria for admission so that we don't give away a bed and then someone who needs it most misses out. Yeah, so that is important.
All right. Looks like Winnie also wants
Then,
to add onto what Charles has just said.
Yeah, something I've forgotten also preparation, because since if a staff who works in the ICU comes to assess the patient, will know the patient's needs, someone from out. So we can know that sometimes you can have a patient who needs the ICU support, but then you realize that you don't have the necessary equipment or things to support that patient. And then you might realize that even if you admit to ICU, you will not be able to support that patient. So it also becomes a different decision. Yes, so also preparation is also the other point. Thank you.
All right, thank you, Charles. Yes, Winnie.
Just to add a bit what he has said most of it. I just wanted to clarify that sometimes this may not be possible in the event where a patient is far away in another hospital or another district or something. But still, that's where the importance of maybe a consult or a handover or still a phone call, detailed explanation from a health worker at the other side to this side. Still, that can act as something like that. But the ideal is to review the patient before. But in the event we can't, there are some intermediates that can help us bridge that gap.
All right, interesting. So Winnie, just before you can hand over that mic to some other person, when Charles went to the emergency department to review this patient, in his assessment, he reported that the patient had cold extremities, had a weak pulse, and the patient had a BP of 160 over 140 over 6 over 80. 85. 140 over 85 millimeters of mercury. And when it reported that, he made mention that the patient was in shock with a BP of 140 over 80. Was he right?
Yes, I think he was right.
Why do you think he was right?
Why I think he was right? So we have other markers of shock. So shock is where generally in a simple time, it could be a state where there is reduced perfusion to organs. So there are different markers of shock, and the most commonly known is a blood pressure, but it's not that definitive or probably standard. In this case, we had other signs of shock. We had a raised capillary refill. We had cold extremities. And also the heart rate was a bit raised. So the compounding factor in this was the patient having a brain injury. That is one. But also sometimes you have compensation by the body in maybe young people or something like that. So the body compensates and gives you a sort of normal blood pressure, and the heart rate sometimes can be raised. So you don't look at just the blood pressure alone, but other markers as well. The patient had also fracture femur, which we know is a very high risk for losing a lot of blood. So factoring in all this, we could actually tentatively say that patient was already in shock, though there are more definitive markers other than just the vitals.
Interesting. Yeah, and this speaks to the fact of not just treating the figures that you're seeing. Put the patient that you're having in front of you into context. For this patient, because of the traumatic brain injury, they might not actually have a drop in the BP to as low as what we routinely know as the BP that would qualify them to be called a patient that is in shock. So it's important to tie down your findings together with the patient's condition. A patient has cold extremities, raised capillary refill, the pulse was weak, and that in itself actually tells us that there is poor end organ perfusion, and which is actually shock. So don't just look at the figures in front of you, but it's important for you to be able to contextualize the figure to the patient that you are managing in the emergency department.
I'm just going to add some emphasis, and this is something I've experienced when I train people. Sure, I like to emphasize that I like to say this, that blood pressure doesn't tell you if someone is in shock. Blood pressure tells you how to manage shock. Most people use blood pressure to tell that someone's in shock. But like my colleagues have already mentioned here, shock starts before the blood pressure falls. And so it's important to find the shock before the blood pressure falls. And most people who rely on blood pressure measurements to tell if someone is shocked, you'll find either the blood vessels are collapsed, or you will be managing the machine. The patient's body will be in shock, but the machine will say the blood pressure is okay. And then your conclusion will be that the patient is not in shock, but what you're meaning is that the machine is not in shock, the patient is already in shock. So what you need to assess is the patient, and the machine guides you. What the blood pressure tells you is simply either be aggressive with your fluid management or relax in terms of your fluid management. So it tells you how to manage the shock, but does not tell you that this person is in shock. So the decision if someone is in shock starts before the blood pressure falls.
Amazing. Winnie, other than the symptoms that we've already the signs and symptoms that we've identified in this patient, could you just walk us through some of those signs that could indicate that a patient is in shock, apart from the ones that we've been able to highlight from this patient?
So apart from the ones we've highlighted from the patient, that is to include the elevated capillary refill, the cold extremities. We also have a reduced volume of the pulse and also the elevated pulse. So you can also have altered mentation. So you're going to have signs and symptoms that show that organs are not perfused well. That is to include the brain. When the brain is not perfused well, you're going to have reduction in your level of consciousness. You can also have altered respiration. The respiration of a patient is going to be abnormal, can I say, can be raised or very low. Yes. And you can also have reduced urine output because that little, very amount of, there is reduced perfusion to the kidney. Yeah. In other times, you can also have liver manifestations. That is to include liver injury. That will be most likely seen on the laboratory tests. Yes.
All right, thank you. Any one particular bedside labs that you would do that would actually tell you that this patient is definitely in shock?
The most important or maybe standard will be a lactate level. Yes, that is most likely seen on the ABG. Yeah, most times.
Yeah, I think I agree with you totally. And now, what levels of lactate would actually speak to shock?
Levels that are more than 2.
More than 2.
Yeah, but some people say 4, but let's take 2.
Let's take 2. Okay, interesting.
Yes.
I think we shall be able to read and just be sure of that.
Mhm.
Charles, would you just quickly take us through the mechanism of shock? Including like the types that we might encounter as we manage patients in the emergency department in the ICUs.
Thank you, Dr. Jimmy. Let me start with the ones that would be a possibility in this patient being a trauma patient. Okay, so one is the hypovolemic, okay, where it can be either hemorrhage, that is bleeding, okay, the other thing would be dehydration. So, but for this patient, of course, since he had a fracture, of course, then the other type of shock is obstructive, or the other mechanism is obstructive. So you can have one obstruction that prevents blood returning well to the heart, and then the heart pumping it the whole body. So if for some patients for these patients didn't show anything like that, as for some patients who get blunt chest trauma, things like that, they get a tension pneumothorax, they can get this. Okay. Yes. Then
And maybe before you continue, I see the obstructive shock could actually also have been a possibility in this patient.
yes.
It's a polytrauma patient, and according to what you have said, is that this patient could potentially also get blunt chest trauma, and they could develop a tension pneumothorax that could manifest with signs and symptoms of shock. And what other examination finding could actually help to identify that this could be a possible tension pneumothorax in this patient, especially if you're assessing a patient of trauma? I think that is quite an important assessment to do, especially for a patient who is manifesting with signs of shock, so that you can be able to catch some of those conditions early enough and be able to save a patient. Are there any particular assessment that we should be paying attention to in a patient who is a polytrauma and is in shock?
So that particular question, I think one of the things is, as I said, the tracheal position is important, because if it is a tension, perhaps you will have displacement, okay, of the trachea to the other side of where the tension is. The other thing also,
The trachea is pushed towards the affected side or towards the normal side?
towards the normal side.
Okay, I think that's quite important, because sometimes we make decisions on how to treat this patient based on that assessment. So it's important to know that when you're having the trachea deviated, the side to which the trachea is pushed is normal, and then the one that is the patient, the trachea has been deviated away from is the one that you should be putting your needle or your chest tube in.
So then the other feature is the neck veins. Okay, yeah. So you obviously the blood is not returning well to the lungs, to the heart, so they will be engorged, they will be distended. So, and in our patients, both were okay, the trachea was okay, the veins were not distended. Then the other thing also in the assessment, of course, the chest. Okay, you can see, you can have one side you might see the expansion of the chest is symmetrical areas, and what the side might not be expanding, and then you have like resonance, percussion, okay, and then might not the breath sounds and all that. But proceeding to the next possible cause of the obstruction can be a pericardial tamponade, where you have blood in the pericardium that can prevent healing of the heart. Then you can also have shock. So that is on the side of obstructive shock. That is a possibility in a patient with trauma.
Maybe just before you move on to the next type of shock, you made mention of the pericardial tamponade, and how can I be able to clinically tell that this patient could actually be having a pericardial tamponade?
Yeah, so a patient with pericardial tamponade, if we have signs of shock, okay, as we all said, then you have distended neck veins. Then when you auscultate the pericardium, you may have a muffled heart sounds. Okay, so that can indicate possibility of a tamponade. Okay, and so then when now you proceed doing the first exam, you can pick it up, and then you need to
okay. Is that the Beck's triad?
Yeah, so
right,
it's the Beck's triad.
All right. So I think just to conclude on this discussion before I can invite Dr. Erasmus to also highlight for us some of those questions that might be important for all the audience to hear. I'll just ask Dr. Rebecca a quick question on what are those priority interventions that you should do in case you get a patient with shock? What are the treatment? Just walk us through the emergency treatment that you give to a patient who is in shock.
So amongst the emergency interventions, obviously, I assume you've done your ABCDE assessment. You want to insert large bore cannulas in this patient. You want to start IV fluid therapy. And depending on the type of shock that you have ascertained, you also want to give oxygen therapy. If this patient is bleeding, you may want to stop, create some form of pressure dressing, or stop the bleeding if you can actively see by applying pressure. You may want to start medication such as tranexamic acid if the patient is bleeding. And in this case, in patients with traumatic brain injury, you will start it if the patient has arrived within 3 hours of the injury. Yes. Yeah, as I said, you also, if it's hemorrhage, you may want to also request for some blood. If the patient, you also have to assess if the patient will benefit from massive transfusion protocol. If they are going to need more than 4 units in an hour or more than 10 units in 24 hours, you may want to initiate a massive transfusion protocol where you're transfusing packed cells, fresh frozen plasma, as well as platelets at a ratio 1:1:1.
Interesting. Thank you, Rebecca, for that. We need to do absolutely. Okay. So I think I'm going to just call on Dr. Erasmus before we continue to highlight some of those questions that were intriguing. And you think that's important for everyone on call to actually get to know the answers to those questions. Over to you, Dr. Erasmus.
Yeah, thank you so much for leading this. It's quite engaging, and I can see from the comments on the chat that people actually do appreciate the way the multidisciplinary team, the coordination. Really, that's what I'm seeing on the chart. A lot of appreciation for that. This is something that's very useful to the audience. Clearly, the questions I've got are covering multiple aspects, and I haven't answered all of them. I'm still trying to see some of them and give responses. But one is regarding the resuscitation period, the assessment and resuscitation period, the primary survey, secondary survey. When do you look at other injuries? And I guess it may not have come out clearly because this is a patient who's being referred, most likely has had a primary survey from the referring facility, secondary survey done as well, and have established a number of injuries already, maybe even stabilized them, and we're dealing with the handover process in this the transfer handover process and the ongoing care in the ICU. So that's why it seems not highlighted or emphasized in this session. But in reality, emergency medicine, intensive care, the hallmark of care is really the ABCs, going through a primary survey, secondary survey, and back. So we are always doing diagnosis, we're doing resuscitation and stabilization and going around and repeating until the patient's out of the emergency scenario, while of course in the ICU instituting the long-term or definitive care. So just remember that the ABCDE and then the secondary survey and other diagnostic tests as needed alongside treatment is what we continue to do even in the ICU, just like it is in the emergency room, just like it's in the pre-hospital setting. The other questions were now around the specific management of raised ICP, given this case we have. People are asking a number of questions regarding osmotherapy, which of mannitol and hypertonic saline is better. The reality is, in terms of the long-term or hard clinical outcomes, there's no significant difference between them if you use them well. The difference is that mannitol definitely is a diuretic, meaning that when you administer it, ultimately it's going to cause diuresis with the patient peeing out a lot of water. And the consequence of that is rapid volume disruption with possible hemodynamic compromise, but also electrolyte challenges with particularly hypokalemia, and possibly even hyponatremia in the long run. So these are things you have to be mindful about when you're using mannitol, that it can actually affect your hemodynamics as well. Also, that if you use it for a while, there's a theoretical possibility that if a patient is bleeding into the brain, some of the mannitol could leak into the brain, the intracranial cavity, and once what is in the bloodstream has cleared out, there could be reverse osmosis where that mannitol then will attract water to the brain and worsen ICP paradoxically. That's later. But this is really not seen in usual emergency resuscitation periods, maybe when you extend the use so much, which is why you need to be careful when you're doing a resuscitation for raised ICP. I'll come back to that in a moment. Hypertonic saline basically means sodium chloride at a higher concentration than what's in our bloodstream. By definition, normal saline has a normal amount of sodium to our blood levels, but because of the high chloride, it becomes abnormal saline. So when we talk about hypertonic saline, we're talking about going even higher than 0.9. We're talking about using 3%, 2.6, 26, 5%, or even 30%. So very high concentrations. So at the end of the day, you're loading a patient with a large amount of sodium with the consequence of increasing the osmotic potential of the bloodstream, which sucks water from the brain, dehydrating and reducing ICP. That water also comes from other cells, which expands the blood volume and improves the hemodynamics of the patient. So people on hypertonic saline tend to have stable hemodynamics compared to mannitol, which causes diuresis. But also because of the hemodilution, you also have blood flowing nicely into the microcirculation of organs, kidneys, lungs, gut, even the brain itself. That's something called rheology. It improves the rheology. It reduces the viscosity and therefore better flow of blood through the body, which improves tissue perfusion. So these are the benefits of hypertonic saline, perhaps relative to mannitol. But like I said, in terms of the long-term outcomes, there's no significant difference between them. So if you have mannitol in your unit, please use it. If you have hypertonic saline in your unit, please use it. There's a debate on whether you can combine them, and most times we want to really consider combining them in patients who are like herniating, but there seems to be no significant benefit of combining them people who are not in that state. So you shouldn't be struggling to do polypharmacy, because when you introduce polypharmacy, you're now going to have a number of adverse events from both agents, and probably failing to determine which one is causing problems. Regarding doses, all these drugs must be given in terms of endpoints. The endpoint, you want to reduce the ICP. So you must determine the signs of raised ICP in the patient, and then you give boluses of these drugs. For mannitol, usually we're talking about 0.5 to about 1 gram per kg bolus, with the aim of reassessing every few minutes of bolusing. Remember, I'm saying bolus, not infusion. When you infuse these hypertonic drugs, the patient's body will adjust. Homeostasis demands that you adjust to a change. So that means if you're going to infuse hypertonic saline, you're not going to get the benefit. You must give it as a bolus of a period of about 15 to 30 minutes, and that will jack up the serum osmolarity and suck water from the brain. If you give it slowly, the kidneys, the heart will release, certain chemicals that enhance kidney elimination of sodium, and so you will not have a significant rise in the sodium and a significant change in the osmolarity. So these are just some guiding ideas about the use of hypertonic solutions. The dose, you keep giving small aliquots. Like I said, mannitol 0.5 to about 1 gram per kg bolus, and then reassess. If it's anisocoria, you want to check if anisocoria is improving. If the GC is low, you want to see if it's improving. If you're going to have imaging, you want to see if you can go back for imaging and see if the edema is improving. And of course, also, if your patient has persistent ICP despite your intervention, you'll be asking neurosurgery if they could come in urgently and potentially consider surgical interventions, because this can only achieve a little temporizing benefit in such patients. Hypertonic saline, generally, we're giving boluses of about 3 to 5 milliliters per kilogram per bolus dose. And that's for a 70 kg man, you're talking about giving about 200 to about 350 mils as a bolus, and then you reevaluate. But generally, for hypertonic saline, there seems to be no significant benefit once the serum sodium is above 160. It just causes more and more adverse events without adding to benefit of the patient. So 3 to 5 mils per kg per bolus dose may raise the serum sodium by about 3 to 5 millimoles per liter. So if you're starting with a serum sodium of about 130, you know that to go above 140 millimoles per liter, you may need to give about 3 boluses of 3 mils per kg to get there before you're worried that you're getting overboard. So some of the things to think about in these patients, but remember, you don't do osmotherapy in isolation. You must do it alongside other therapies so that you achieve a goal-directed outcome in the patient, including especially in these trauma patients involving neurosurgery, where they might be helpful in surgical interventions. I think the final questions I'm seeing on the chat are really about sedation, what sedative should be given, and what, So in general, the idea is the patients who are to be sedated must have a secured airway, because sedatives tend to knock out the patient's ability to protect their airway and also the ability to breathe. So you must be adequately ventilating these patients, and you've secured the airway. Then in terms of what you choose to use, number one is you need a sedative that lowers the brain metabolic activity by depressing the brain activity. Because the goal of sedation in these patients is to lower the metabolic rate of the brain to match the little brain perfusion that is coming through. So you want a drug that will lower the metabolic rate while maintaining the perfusion of the brain, such that in the end the ICP will reduce. Remember, while the ICP increases, the brain perfusion decreases because of the pressure that resists blood flow. So you want to lower the brain metabolic rate so that's no longer metabolically demanding blood flow, so that the little that is delivered is enough. So you want to use a drug that does not lower the blood pressure significantly, but significantly reduce the brain's metabolic rate. So the best drug doesn't exist, unfortunately. So now you have to select drugs based on what's available to you, but has those characteristics of lower the brain metabolic rate, but being mindful of its adverse events. For example, Propofol is one of the best drugs for lower the brain metabolic rate, but it is notorious for dropping the blood pressure in any patient, but especially in trauma patients who might be hypovolemic as well. And yet dropping the blood pressure means poor brain perfusion. So you may be careful about it, or at least start an inotropic suppressor alongside propofol, where it might drop the BP. Then midazolam might help as well. Barbiturates like phenobarbital or things like thiopentone infusion may be helpful, but again, they also drop the BP. So you have to be mindful about that component. Drugs like ketamine are probably the best drugs to use for this purpose because they drop the brain's metabolic rate, but also somehow support the hemodynamics in the patient. They don't drop the BPs directly. However, of course, in very high doses, they can. In patients who are extremely, extremely stressed out, having suffered from this reflux for a long time, it can also drop the BPs. But that's really the idea. Select a drug for its benefit and try to be mindful of its adverse events and intervene appropriately. So far, those are the questions I'm seeing on the chat, and some of them are recurring. And I hope that those answers will help people to at least choose wisely bedside and help in these patients. Thank you. So over to you, moderator.
Thank you so much, Dr. Erasmus. I think those were very comprehensive answers, especially in regards to management of ICP, which I think was also partly the gist of this discussion. Maybe before we can end, I'm going to give opportunity to at least two participants to ask their question or give comments. And now the simulation went, and maybe if there are any particular highlights that they would love to hear. Just raise your hand and I can be able, I can already see Beatrice. Beatrice, you could go ahead and unmute and ask your question.
Thank you. Thank you, everyone. The presentation has been so good. My question is logistical, really. If our patient was at Mulago already. If I am in a small center and I can recognize that the airway is compromised, I've done my primary, and I can intubate, is it okay for me? I guess I'm wondering what you guys would do. Would it be okay to intubate and then move to Mulago? I don't have knowledge of I can't talk to the intensivist, but I'm in a center that has no ICU, and I know I need to protect the airway, and I have a method of a definitive airway. Should I go with the patient with an unsecured airway, or is it okay if I arrive to a larger center without that initial call to ICU?
All right, thank you. I will give that to Dr. Erasmus to answer. It's logistical, but also I think still medically important in regards to how do we actually get the patient to the next point of care. Do we just rush because the patient actually needs maybe some service that you don't have in your setting? Just like we said, sometimes you would actually want to rush the patient to Mulago and you get to realize that all the vents are occupied and we do not have any available vents. But yeah, I will let Dr. Erasmus expound on it.
Thank you very much. So I want to first disabuse one misconception out there that ICU is just a place for ventilation. In other words, once ICU says they cannot ventilate, that means you're not going to intubate a patient. Intubation is part and parcel of the primary survey. Okay? ICU will benefit from a well-resuscitated patient who has been saved from in the golden hour and optimized for better outcomes, rather than one who has been, politically pushed without appropriate care, and they end up eventually coming to ICU when they are vegetables because their airway was compromised and soiled because they vomited on the way, or because they were not ventilating adequately and therefore they were quite hypoxemic and hypercapnic. Remember, there is something called primary brain injury when you have suffered brain injury. That is injury we cannot reverse as medics, and maybe prophets and witch doctors can pretend that they can do something about it, but in truth, once it has happened, that injury has happened. Now, what we are doing in medicine is avoiding secondary brain injury so that eventually we can go towards the tertiary component, which is rehabilitation or getting person back to their baseline if possible. So that means when a patient has suffered injury and they are unconscious, not protecting their airway, they have met criteria for intubation. Whether you have ventilators there or not, they need a secure airway. Now, once you intubate, of course, you have responsibilities for that airway. One is to keep it in place so that it doesn't get dislodged. Second is to make sure that it's patent so it doesn't block and now the patient suffocates under you. That means you should be able to do suction and the like. The third is that during the process of intubation, you might have sedated the patient or even paralyzed them, and so they're not breathing. So you must be able to provide them with ventilatory support along the way. It is better to deliver such a patient who is intubated, ventilated, and optimized to Mulago Hospital and let Mulago tell you that somehow they do not have the resources to support the patient, in which case either the family might be able to recoup resources from the community and get them to a private or private not-for-profit facility for support on another ICU where they might continue care. Or if this is not totally possible, maybe they might be able to transition to a tracheostomy and then continue support of the patient without ventilation where feasible, and give them a chance. Or even at worst, if the team determines that everything is futile, the patient can only survive with the ventilation, but unfortunately the resource not available and the family cannot afford it completely, then the conversation about end-of-life care may begin. But leave that decision to the experts. Your job is to provide the care to the patient and deliver them. And this goes to emergency room physicians as well. The patient who meets the criteria for intubation should be intubated. You do not wait for ICU to tell you that we have space, then now you intubate to bring to ICU. You do not wait for the patient to reach ICU and they get intubated. No. Intubation is part of airway protection, which is independent of needs for ventilation and oxygenation. You should provide that care to patients. And if it is not feasible to find ICU space, it is okay to withdraw an intervention that has been deemed unnecessary at that point. But while it was necessary, please perform it. Thank you.
Thank you so much, Dr. Rosma. I think that's quite helpful. I'm just going to give one more chance. I'm cognizant that we started 5 minutes late, so one more question, then we can wrap it up. All right, looks like we don't have any questions, so I'm just going to invite the panelists to give us the cutting shots, and then we shall be ready to close this discussion. I'm going to begin with Simon, who ran the case. What was your cutting shot? What are the key learning point from this scenario that anyone who has been on call should disclose in 1 minute?
Thank you, Jimmy. Thank you for all that I've stayed until now. I think my parting shot is to remind people the importance of the primary survey. I think from the simulation scenarios, this is the third one. We've seen how there is the same conversation is had right from pre-hospital in Masaka to the pre-hospital setting, and then to the ED, and now to the ICU. So that uniformity of conversation is usually what we preach in emergency care. And we hope that everyone can have it at the back of their minds, that even when they wake you up from sleep, it's something that you don't have to think about. So that's my part.
Thank you, Simon. I think that's quite important for anyone. Brenda, with the mic near you, could you just tell us what your cutting shots are as a nurse? Who was managing this patient? What should the nurse take away from this talk?
Okay, thank you so much. As a nurse who is managing any patient that you come across, first of all, the primary survey, we've seen the importance of the primary survey. And then, so when you're caring for the patient, care for the patient. Don't look at the monitor as if it is the patient. That is my take home. And also to encourage my nurses out there, when you're working for the patient, kindly look at the patient. Don't wait for the machine to lead you astray. So look out, or also think beyond the machine so that our patients are well taken care of. Thank you.
Thank you so much. I think that is quite an important take home. I will allow Kathy to also tie it down. What is that key thing that you'd love any nurse who has been on call to go away with? In that a second.
Thank you, Dr. Jimmy, and thank you, the team that is listening in. As a nurse working in the ICU, the take that I have for all the nurses is we should do a thorough assessment, the ABC for our patients, and then we should also take note to tailor the monitoring vitals to the patient's presentation, so that we are not just monitoring the machine and not tailoring it to how the patient is presenting at that time.
Thank you, Kathy. I think that's quite important. Rebecca, as the person who's working in the emergency department, you're probably going to always be the first person to receive such a patient. And what should any person working in the emergency department take home from this conversation?
Again, the importance of the primary survey. The importance of teamwork. I hope we've been able to appreciate it for the last 3 sessions. You can't work as an island. Everyone on that team is very important in achieving good clinical outcomes for your patient. The nurses, the doctors, whichever the cadre is, even as far as the cleaner, everyone is important on that team. And also the importance of multidisciplinary care, which I hope you were able to appreciate, and the way we communicate those non-technical skills, the way we communicate between teams, the ISBA that we have managed to demonstrate in all 3 sessions, I hope we're all able to appreciate. Thank you.
Thank you, Rebecca. I will also allow Charles to give his cutting shot.
Thank you, Jimmy. I normally talk much, but I'm going to
30 seconds.
Yes, so I think I would say structured closed loop communication is critical in managing critically ill patients. Thank you, Jimmy.
Thank you, Charles. That was quite brief and very concise and precise. I will also allow for Winnie to also give a cutting shots.
Thank you, Jimmy, and thank you, Tim, who have participated and those who are listening. Mine is an overall cutting short in terms of communication. We've emphasized the ISBA, the vitals, and the patients. My take home is more the fact that in Uganda, all of us are prone to trauma a lot, and maybe any other diseases. So the skills we are getting, technical and non-technical, are very crucial, because any of us can be in these positions we're talking about and would like to be saved quite perfectly, even if none of us, maybe our close relatives and loved ones, you'd like to see that maybe they got an accident, they moved from this place to another safely, and their lives were restored. So I would just like us, while we are listening, while we are practicing, to be passionate, because this is closer to home than anything. Thank you.
Thank you, Winnie. That was quite emotional as well. All right, so I'm going to invite us to turn on our videos, then we can take the screenshots for that day. And again, we appreciate everyone who has always labored to call into this session. This has been a simulation of a trauma victim, and we all know that Uganda has very high incidences of trauma, and it's quite important that we get to know how to safely and adequately manage trauma victims, and also get to know when do we need to escalate care and when do we need to, when can we keep them around in the facility, depending on the level of facility that you're working in. And this has been the end of the simulation for this particular case. We look forward to the next case that we are going to be simulating. So the idea behind the simulation is to be able to translate the knowledge that has been shared into practical skills that you can be able to use in the emergency department, use in the ICU, or even pre-hospital, to be able to safely manage trauma victims, manage whatever emergency condition that you're going to be encountering. And we look forward to having you in the next session. Yes, and we hope that these skills that are demonstrated, you will be able to translate them into patient care in the facilities that you are operating in. Thank you all. Some people are still have not yet put their videos on. Thank you, James, Peter, Odokor for calling, Kemigisha, Charity from Barara. Thank you so much for calling. We can see you. Thank you, Ambrose Okelo, Mima, Dennis Obong, Rachel Kwagala, Isaac Ojok, thank you for calling. Otieno Jackson.
I cannot put my video on.
All right, thank you.